Hello you guys, welcoming all for our study section. I'm truly sorry for such a delay for dropping this video. I have been preparing this topic and was astonished the way its treatment have rejuvenated. I'm talking about the topic COPD, chronic obstructive pulmonary disease, very commonly seen in our wards. COPD has some special space in our wards. Its prevention treatment keeps on getting better day by day. Let's just quickly jump into the topic and learn more. Persistent respiratory symptom and airflow obstruction, that is the COPD. So we have the chronic bronchitis, we have the emphysema. So let's just have a quick recap of what are those. Chronic bronchitis is a chronic cough which is persisting for more than that of the 3 months and for 2 consecutive years. Okay, mostly occurring in smokers obviously, and also called as blue bloaters. Okay, there is a small airway disease, right? So the small bronchioles are narrowed and reduced in number. So why is this happening? We'll see in the pathophysiology. For now, just remember there is a small airway disease which is occurring in this chronic pulmonary disease, and small bronchioles are narrowed. Emphysema is destruction of the lung alveoli with the airspace enlargement. Why is this happening? We will be studying in the next slides. And we have something which is bronchiectasis, which is also an obstructive disorder. Traction bronchiectasis, rather I will say, is a more of the restrictive pattern. Otherwise bronchiectasis is an obstructive pattern. So the bronchiectasis is nothing but destruction distal to the terminal bronchiole. Okay. Then we have the this is something which is just a fact, and it can be asked in one or the other MCQs. MUC5B, okay, MUC5B gene, which is produced by all the airways. Mostly it is produced by submucosal glands. So the pathogenesis lies, there is a physiological marker and there is a hallmark of COPD. Physiological marker says there is a airflow obstruction. Now why is there airflow obstruction? Because of the smooth muscles hyperplasia and hypertrophy, we have the mucus production, right? Mucus and goblet cells hyperplasia is seen, and there is also related to it we have TGF beta and other fibrotic release of the inflammatory markers, and then there is fibrosis. So the hallmark of the COPD is the extensive small airway destruction. So remember, the small airways are seen everywhere. You will be seeing the small airways which are emphasized. Then there is heterogeneous presentation. That means all the patients will not be presenting with the similar complaints. Some will be coming with the acute exacerbation of COPD, some will be only having say tachypnea or something like that, or some will be only with the chronic cough, that's it, but they won't be having same set of symptoms, right? Then this is a graph which is I have taken it from the Harrison. Now this is this says that whenever patient is having a COPD and a non-COPD, so what is the relationship between the FEV1 and the age? If you see a patient with a COPD, he would be with the age, the FEV1 will be declining. Obviously, FEV1 is less. Okay, in this obstructive patients, FEV1 to FVC ratio is less than that of 0.8 and everything. But with the age also, it will be decreasing. And if the patient is a non-COPD, of course, with the age, the lung function declines. But when we compare to a COPD patient, there would be not much of the difference. Okay, so the lung mature by 20 to 25 years of the age. Lung function declines with the age. FEV1 depends on the birth weight. Now if the patient is a premature child, or he has had a recurrent infection in the past and during like TB or something during the childhood, so he is more predisposed to have COPD and other infections, right? So it depends on the birth weight. Accelerated aging seen in COPD, abnormal lung growth and accelerated decline predisposed to COPD, birth infections predisposed to COPD. So there is this dissynapsis So there is mismatch. See, like kidney also, kidney, whenever we say patient which is just short or something, we say that if the kidney is, say we have 7 into 5 centimeter, or we have 6 into 4 centimeter, according to his tallness or something, anthropometry, we will be saying that he is okay for that, that kidney size is okay for his height. But now even here we have this tall person will be having more of this lengthwise, and then short person will be having a relatively shorter size, or the shorter anthropometry, right. There is obviously mismatch. Okay. Now this also predisposes to COPD. We call it dysynapsis. So remember, there is a mismatch of the air tree caliber, and this is called as dysynapsis. Okay. We have seen that MUC5B, and then we have AC also, which is actually proximal, seen in proximal glands, which is goblet cells, right. Now, what are the events which are taking place? So, we know that there is genetic susceptibility, plus there is smoking history. This is very, very important, smoking, right. And alpha 1 antitrypsin and everything, antiprotease and everything, will be seeing that. So, this is the basic pattern that we all know, and that we'll be discussing it, but we need to get through the edge also. Why is it happening, and what all are the pathophysiologic markers and everything. So, chronic exposure to cigarette smoking with the start of the genetic susceptibility will lead to inflammation. Okay. So, inflammation of the small airways. Now, inflammatory cells release that of the proteases. Now, this proteases is not good, right. So, it damages the extracellular matrix. So, there is cellular aging, there is senescence which is taking place, there is inflammation which is taking place, there is oxidant damage, and there is the proteolytic release of the loss of the cellular matrix because of the proteinases. This all leads to a structural cell death, and wherein there is extensive loss of small airways and vascular pruning, airway destruction. Again, there is a destruction which is taking place, so this should be repaired, right, by the body. But there is also in disorder repair of elastin, and there will be airspace enlargement and emphysema. So till date we knew that smoking is one of the fan, then genetic factor is there, alpha 1 antitrypsin deficiency is there, right. But what are the events which are taking place? So first of all, there is smoking, there is genetic susceptibility, which will lead to release of inflammation. Inflammation leads to proteases, which leads to loss of extracellular matrix. Now we have this proteases, we have the oxidant damage, we have the cellular aging, which will lead to structural cell death. Now this death is occurring, and then there is no effective repair because by the elastin, and that will lead to airspace enlargement and emphysema. Inflammation and extracellular matrix proteolysis. Now there is this elastin, right, which is a principal component of elastic fibers, which is highly stable. So we know that alpha 1 antitrypsin deficiency, inhibitor of serine protease and neutrophil elastase. The elastin degrading enzymes, okay, and their inhibitors determine the susceptibility of the lung to destruction, and there is airspace enlargement. So this is, we are talking in genetic wise. So this is a table wherein we saw cigarette smoking and the genetic susceptibility leading to inflammation, neutrophil, macrophage, epithelial cells, lymphocytes, right. One by one, protease and antiprotease. So we saw that there is extracellular matrix destruction, but via what? Via MMP12, serpinagene, neutrophil elastase. Okay, matrix metalloprotease 12. Then we have oxidant and antioxidant, that is leading to chronic inflammation, right. So there is also NF kappa beta and NRF2, SOD3, SDSC2. These are mediators. Apoptosis cell death because of the RTP801 ceramide cell death. Okay. Lung repair, TGF beta, elastin, which is causing ineffective repair. Elastin we knew, TGF beta is also there. So revising it all, these are important, asked in MCQ. So if it is an protease, antiprotease, serpinagene, right, then MMP12, okay, neutrophil elastase. Then we have oxidant and antioxidants damage which is occurring, there is NF kappa beta, SOD3, then we have the HDAC2 and NRF2. Apoptosis, RTP801 and ceramide, which is causing the cell death, lung repair, elastin, and along with TGF beta. Okay. Then the cigarette smoking. Okay. that will be leading to release of the IP10 and CXCL7, production of macrophage elastase and MMP12 matrix metalloprotease. So many patients just ask us if we have abstinence to cigarette, or we are having nicotine gums and everything, and now we are like since 5 years or say 2 years I am not smoking. So will this disease get reversed, and it will I be cured? So why will it be cured? Whenever the patient with a cigarette smoking is having a chronic inflammation, so even if he or she has an abstinence to it, there the chronic inflammation progresses, and there will never be a reversal to the patient will not be going back to the age of the lung that he had previously. So the aging has took place, the fibrosis has took place, there is emphysema. No. So the answer is strictly no. We have a matrix metalloprotease and a serine proteases, right? So we have seen that MMP12 and serpina gene also we have seen. So neutrophil elastase is the most potent secretagogue which is causing the lung destruction. So remember, there is a proteolytic cleavage of the elastase which serves as a macrophage chemokine, and there is a proteolytic cleavage of the collagen, okay, which serves as a neutrophil chemokine. So remember me, macrophage chemokine, elastin, okay, collagen, neutrophil. Now whatever, if a patient is having any autoimmune disease, any of them, so he would be more and he also has certain COPD, but a mild type, or we say that according to ABCD he has only the A component, nothing else, there will be progression of disease, okay. So it is because of the increase in the B cells and lymphoid follicles, okay. IgG autoantibodies will be contributing to it. Then concomitant cigarette smoking, so with that of the genetic accessibility, okay. So what does cigarette smoking do? There is a loss of cilia in the airway epithelium, and there is impaired macrophage phagocytosis, so which will lead to that of bacterial infection and neutrophilia. So cilia is something which is causing the movement, right? Now whatever secretions or any of the microorganisms or anything that is it is trapped in the cilia, now it will try to throw out, okay, this by trapping it or causing the death of the that organism, it is a prevention, okay, it is a preventive mechanism. But whenever there is smoking, the cilia is not present, or they have the macrophage have the impaired function, so the bacteria will proliferate and there will be infection. Even after the smoking cessation, there will be exuberant inflammatory response, chronic inflammation, disease progression will take place. Two genes, GWAS, HHIP, genome wide associated disease, hedgehog interacting protein, okay, this is related to age related emphysema, GWAS and HHIP. Pathology like smoking, which affects large airways, small airways, alveoli. Large airways, we will see it is a chronic bronchitis, okay. So gold has this 1 2 3 4 A B C D, now it has A B E, according to the A B C D has been revised into A B E, okay. Mild, moderate, severe, very severe. Whenever the FE1 FVC is less than 0.8 0.7, we say it is an obstructive disease, no doubt. So we say FE1 is more than equal to 80%, okay, that is only mild. FE1 is less than that of the 80%, but more than that of 50%, 50 to 80%, that is 3, that is 2. Then we have 3, okay, severe. So that means there will be FVC is less than that of the 50 but more than that of the 30. Then very severe, that is less than that of the 30% FEV1. Okay. So larger airways, cigarette smoking, mucous gland enlargement, there is a goblet cell hyperplasia. So whenever it is a chronic sputum which is present, always try to figure out if it is a chronic bronchitis, because there is goblet cell hyperplasia which is causing cure for the mucus production. There is smooth muscle hypertrophy and hyper reactivity that is causing the airway obstruction. So airway obstruction is because of the smooth muscle hypertrophy and hyperplasia. There is the edema which is present, taking inflammation because of the inflammation. There is the mucous gland enlargement. So there is the mucus which is present. over here. Okay. So, the small airways have a goblet cell metaplasia, smooth muscle hypertrophy. There is section luminary because of mucus, because of edema, because of inflammation, infiltration, cellular infiltration, fibrosis. And also, major thing, there will be increase in surface tension because the surfactant producing cells are replaced by the mucus producing cells. Okay. Then there are types: centrilobular emphysema, panlobular, paraseptal. Centrilobular emphysema, that is related to that of the smoking. Mostly the upper part is involved, upper lobes are involved. Okay, like this, upper lobes are involved. And panlobular is mostly because of genetic alpha 1 antitrypsin deficiency. Mostly there is actually lower lobes are involved in this. Okay. Then paraseptal, mostly the lowest part, that is this related to pleural margins. Paraseptal emphysema. So this is the pictorial, upper lobes, lower lobes, and only the pleural margins not appreciated enough. So there is reduction in the forced expiratory flow rate, airflow obstruction seen, FE1 to FEC ratio is decreased, there is air trapping, there is hyperinflation. Also DLCO will be decreased in fibrosis because of the fibrosis. Then there will be due to the hyperinflation, there will be flattened diaphragm. We have many of the time we have discussed this topic with our colleagues, and we have also studied. So there is and we have even appreciated in the patients. And also there will be tubular heart because of the hyperinflation. So what are the adverse effect of flattened diaphragm? Very important. Firstly, there is decrease in the zone of the opposition between the abdominal wall and the diaphragm. The positive abdominal pressure is not applied, and which is impairing the inspiration. Second, the muscle fibers of the diaphragm are flattened and short, thus are less capable of generating inspiratory pressures. The flattened diaphragm must generate greater tension to develop the transpulmonary pressure required for tidal breathing. Thoracic cage expanded inspiratory muscle must do work to overcome the resistance. The risk factors: smoking in pack years, airway hyperresponsiveness, and COPD. Both asthma and COPD are the risk factors. Okay, respiratory infections, occupational exposure. Of course, it is not only the occupational diseases which are related to the occupational exposure. It is all the other diseases can be exacerbated, right? Air pollution, passive smoking, alpha 1 antitrypsin deficiency, sarpinagene, right? We have a M allele and we have a Z allele. When Z means it is dangerous, M is okay, the mild type only. Then PIZZ, severe emphysema. We have something which is called as pre-COPD. Pre-COPD means there will be symptoms, the FE1 will be decreased, okay, but FE1 to FVC ratio is preserved. That is the pre-COPD, and symptoms are present, FE1 is decreased, CT scan shows emphysema, DLCO is decreased, okay, that is pre-COPD. Then we have preserved ratio and impaired spirometry. This occurs in 7 to 20% of the patient may or may not have COPD. Okay. Remember, 30% of the patients of COPD have developed bronchitis. Okay. So this recently I have found out one of the patient, that patient had on the HRCT bronchitis, but there was no evidence of emphysema. But then when I took the history, she said that she was a chulha maker, and I could easily find out that she is actually a obstructive pulmonary disorder, but along with that she has developed the bronchiectasis, and of course I had to give mucomics and nebulization along with doxo or theophylline. Then we have the airway disease, that is the FE1 to FVC ratio is preserved ratio impaired spirometry, we have already seen that. Clinically, we have the, obviously the patient will be tachypnea, will have tachycardia, will say that whenever the weather changes he is having problem in breathing. Okay. So the usage of accessory muscles and respiration better tolerated. Significant arm work or above the shoulder is hampered. Pushing a shopping cart or walking on a treadmill, he will not tolerate that. There is pulmonary vascular remodeling. okay, causing pulmonary hypertension. Actually, this is because of the hyperplasia which is taking place, hyperplasia and hypertrophy. Okay, pulmonary hypertension due to hypoxic vasoconstriction is seen, and there is decrease in the alveolar capillary surface area. Okay, so pulmonary vascular modeling, very important. Right heart failure can occur, and seldom it is seen that whenever patient is with PAH. Okay, remember COPD predisposing to PAH. Okay, do not prescribe him sildenafil. Okay, this results in hypoxia. We will see that later. Okay, we have made these mistakes, we need to correct this. Physically, we have a odor of smoke, then nicotine staining of the fingernails, prolonged expiratory phase, there is a wheeze, barrel shaped chest, tripod position, usage of accessory muscles, cyanosis of lips and nail beds. In advanced disease, there is loss of weight, right? And this is because he will not be able to take nutrition properly, and also there is the elevated levels of TNF alpha. There is Hoover's sign, which is the paradoxical inward movement of the ribs during the inspiration due to chronic hyperinflation. There is no clubbing. If clubbing, COPD, suspect COPD, okay, or otherwise bronchiectasis. In young COPD, that is 25 to 50 years of age, of course genetic. FE1 to FEC, there is decrease, obstructive pattern. Okay, severe cases RV, TLC, FRC is increased, DLC is decreased. Okay, we have certain BODE. Now BODE is just a MCQ topic. Okay, not used frequently. BMI, obstruction, dyspnea, exercise intolerance, that is better predictor of mortality. We have something which is Dahlsen or Thinkerson. Whenever patient sits in a tripod position, he or she would be keeping his elbow and the arms over the thighs, and that will be causing pigmentation of the thighs. Pursed lips, PEEP maintained. That's why patient is having a comfortable position, relatively comfortable position, alveolar open during expiration. So this ABCD has been into ABE, okay, according to the new guidelines. So in the acute state, we have the PCO2 retention, okay, more than that of the 45 mmHg. Okay, we will see acute or chronic condition, acute respiratory failure, and there is acidemia. So if it is an acute state, 0.08 units per 10 mmHg, and if it is a chronic state, change in pH would be 0.03 units per 10 mm, 0.08, 0.03 acute, chronic. Of course, hypoxemia will lead to increase in the RVH, there will be RVH, there is increase in the hematocrit. Okay, so that was the pathophysiology, okay, and the genetic susceptibility made it very clear. Coming to the treatment part, we want the symptoms to be relieved, and we do not want exacerbation, future exacerbation. So we have this ABCD. A stands for we always go from here, okay, to here to here. Okay, A stands for low symptoms, low risk, then the symptoms increasing, the exacerbation increasing. Symptoms, so it is the CAT. Okay, CAT assessment has to be done. Okay, so wherein the CAT scale says there would be chronic cough. Okay, there will be mucus production, phlegm, there will be chest tightness, there will be dyspnea. He won't be having that confidence of leaving house, limitation of home activity. So it is the range between 0 to 40. Okay. Again, there will be high symptoms in B and low risk. There will be low symptoms but high risk. High risk, that means exacerbation. Now, this exacerbation should be, of course, with the hospital admission, 1 episode of hospital admission. So then we will be saying the patient is C or D if there is a hospital admission present. Okay, history of hospital admission. We use bronchodilators, of course, LABA or LAMA. Okay, we will see what are the guidelines. Then there are muscarinic antagonists. Tiotropium is a drug of choice. Ipratropium is short acting. Muscarinic, we have, of course, the glaucoma. There is urine retention. There is a dryness of mouth. Okay. We have beta agonist, short acting, long acting. Okay. So this was the table. So group A we use a bronchodilator, okay. Group B we can use a long acting bronchodilator, LABA or LAMA. So there is short acting can be used over here. Then group C we use LAMA. Group D needs inhaled corticosteroids along with LABA and LAMA. So if there is a LAMA and LAMA or LAMA is used and the patient is not relieved, then we will combine both of them. And if even if it is not, okay, then we will be adding inhaled corticosteroids to it. During the exacerbation, remember eosinophil count is very important. If it is less than that of the 100, no inhaled corticosteroid, okay, no extra benefit of inhaled corticosteroids. So what will give then? We give phosphatase inhibitor roflumilast. Okay, roflumilast is given. If E1 is less than 50% chronic bronchitis, then roflumilast is given. Okay. Of course, azithromycin decreases the exacerbation, very important. So along with the inhaled corticosteroids or oral corticosteroids, azithromycin also decreases the exacerbation. So LAMA LABA, okay, adding LABA LAMA inhaled corticosteroids, roflumilast is given if even is less than that of 50% and in chronic bronchitis. But remember, roflumilast only given if the BMI is more, because it causes weight loss. Okay, low BMI patient not given. Inhaled corticosteroids decreases exacerbation, very important. Less than 100 eosinophil count do not benefit. Frequent exacerbation more than 2 per year or in patients with a hospitalized, okay, with one exacerbation given. Oral corticosteroids used mostly in exacerbation, decreases the stay in the hospital. So is there any role of IV MPS? No. Guidelines say no role, but still given in many of the hospitals because the patient is relieved, symptomatically getting better, but no role of IV. Oral can be tried after inhaled corticosteroids. Theophylline is a low therapeutic index, we know that. Okay, monitoring is required. Phosphatase 4 inhibitor, that is decreases the exacerbation. Roflumilast, hypotension, nausea, vomiting, headache is the side effect. In the antibiotics, we have azithromycin, which decreases the frequency of exacerbation. Oxygen supply, in case of two important indications, if it is less than that of the 88% of SpO2, we need to give. If it is less than 89%, along with that of the right heart failure or PH, then we need to give oxygen. Alpha-1 antitrypsin augmentation therapy coming up, not seen in India, more like it is coming up, right? Recent advances like that. Hepatitis B vaccination is essential, okay, along with the alpha-1 antitrypsin augmentation therapy. Whenever the levels are less than that of the 11 micrometer, this is the indication, okay. PIZZ type, okay, dangerous one. Vaccination is important. For vaccination, we have zoster, we have the pneumococcus, we have the influenza, we have the COVID, we have the pertussis. Of course, influenza is very important, which is causing the decrease in exacerbation. Lung volume reduction surgery, okay, it is included in National Emphysema Treatment Trial. Upper lobe predominant emphysema patients are subjected to this lung volume reduction surgery. Now, where is it contraindicated? If the emphysema is diffuse one, we cannot reduce the lung volume. Then DLCO is less than that of the 20% and FE1 is less than 20%. Lung transplantation, most important indication for the lung transplantation is COPD. So, see, it is done in, if the FE1 is less than that of 25%, a very severe airflow obstruction, PaCO2 more than 50 and PaO2 less than 60, severe disability despite maximal treatment, body index is 5 to 6 and no comorbidities. So, we have this lung transplantation. So, very severe airflow obstruction, okay, body 5 to 6, FEV1 less than that of 25%, comorbidities, no comorbidities, okay. Then if the PaCO2 is more than 60 and PaO2 is less than that of 50, okay. So, and maximal treatment is given, still the patient is not recovering, then we need to give the lung transplantation. We need to think of lung transplantation. So the risk factor that is important for the future exacerbation is prior exacerbation. Okay, always ask the history important. So whenever having exacerbation, we know altered mental status, pulmonary embolism, pneumothorax, tachypnea, tachycardia, and Hoover's sign, paradoxical inward movement of ribs. So we need to keep this in mind. Pneumothorax, we need to check. Okay, very important. Normal X-ray sufficient enough. Most common indication for lung transplant is COPD. Now we have nicotine replacement. Okay, now many of the patients are compliant to it also. Okay, we have chewing gums, we have transdermal patch, we have nasal sprays. Transdermal patch available in 7, 14, 21 milligram. Now the one packet has 7 of the transdermal patch. Each patch works for 24 hours. So we need to change it every day after every 24 hours. Now nicotine not good because of the constriction that is taking place, and ACS and stroke less than that of 2 weeks, contraindicated. Always ask the history. Now e-cigarettes and vaping, many people think that e-cigarette is a replacement. No, it is not a replacement. It is not as bad as the smoking, whatever the conventional cigarettes are there, but it also causes acute lung injury, DH, bronchiolitis, not very good. Both produce nicotine, there is a pleasurable effect. Okay, so but it produces this tetrahydrocannabinoid, diacetyl vitamin E acetate, vegetable glycine, flavoring agent, okay, propylene glycol. So these chemicals are causing eosinophilic pneumonia, bronchiolitis, DAH, and acute lung injury. E-cigarettes and COPD causing neutrophilic infiltration, bronchial hyperresponsiveness, mucus secretion, okay, and ciliary dysfunction, predisposing to COPD, e-cigarettes. Okay, so avoid giving this e-cigarette. Nicotine is fine. Okay. 5-step program for intervention. Ask, that is a smoking habit, then advise for cessation, assess the willingness, assess, that is counseling, okay, and arrange, that is the review. Vaccination, influenza, zoster, pneumococcus, COVID-19, pertussis need to be vaccinated. I know not followed in government setup, but very important if the patient is affording. Okay. Influenza vaccine reduces the serious LRTI and exacerbation. Pneumococcal vaccines, conjugated always better than polysaccharide. Conjugated we have 15, 20, 13 and PSV 23. If 15 is given, we need to give one PPSV 23. If 20 is given, no need of any polysaccharide. So currently 15 followed by PPSV 23, one dose of PCV is enough. Only if the PPSV 23 is received, PCV to be given after the last dose of PPSV. Okay, conjugate better than polysaccharide. Blood eosinophil count, we have already studied. If it is less than 100, no use for the inhaled corticosteroid along with the LABA. 100 to 300, look for the clinical profile of the patient, and more than 300, that inhaled corticosteroid is prepared. Recently coming up, we have triple therapy, LABA, LAMA, inhaled corticosteroids. Very, very effective, very good. Okay, efficacy wise. Phosphoryspore inhibitor, roflumilast, decreases the moderate to severe exacerbation in chronic bronchitis and severe to very severe in COPD, causes loss of weight. Its action is for 24 hours. It is not recommended for low BMI patients. Now, we have certain drugs which have no benefit. Okay, do not even try. They're such as beta blockers. Okay, it will do no good to the patient. Vitamin D. Okay, then TNF alpha antibody. Statins, okay, leukotriene modifiers. Vasodilators, sildenafil and tarafilin may worsen oxygenation, very important. Do not ever try this. Many of them have been given severe pH, sildenafil has been added, but wrong. Alpha 1 antitrypsin augmentation therapy, we have already seen. PIZZ allele less than that of 11 micromilliliter. Okay, young who are not even a smoker, young individuals who have genetic susceptibility, those who have been smoking but have reduced or stopped smoking and still the patient has been progressing with the disease, there we can all try. Okay, decreasing progression of the emphysema, non-smokers, ZZ phenotype, FE1 is 35 to 60%, progressive disease despite of smoking cessation. Palliative oxygen therapy is not recommended in ATS guidelines. Nutritional support is very important. Severe hypoxemia, if we find out there is severe hypoxemia, then long-term oxygen therapy is tried. NIV support, very important in case of OSA along with the COPD, or CPAP trial is given in this, or the patient is discharged and say he is still tachypnea and hypoxia persists even after 2 to 6 weeks, then NIV support is needed. Okay, so persistent hypercapnia after 20 to 4 weeks, NIV is given. NIV support decreases the mortality and with the hypercapnic patient. Okay, there is also bullectomy, one of the procedures that can be done whenever there is a giant bulla which is found, and so that it will not progress to pneumothorax, then we can have a bullectomy done in these patients who this causes the more than that of the 1/3 of the hemithorax to be removed. Inhaled corticosteroids along with the LABA is not recommended by GOLD. Now, certain guidelines have the certain prevention strategies and everything. So, just remember that if the MCQ says that ATS guideline is not recommending the palliative oxygen therapy, then the GOLD guideline LABA, but still it is used. Okay, many of the centers they use this, and it is found that patients are reliable on it. They are benefited by it. Okay, so no problem. So thank you everyone for watching this. I hope you enjoyed this video.